page 575. International Textbook of Diabetes Mellitus, DeFronzo, Ferrannini, Zimmet, Alberti, 2015. Section 8. Management of Diabetes, Diet, Exercise and Drugs. Chapter 40. Dietary Management of Diabetes Mellitus in Europe and North America. Mann and Alexandra Chisholm. Department of Human Nutrition, University of Otago, Dunedin, New Zealand. Obesity Research Centre, University of Otago, Dunedin, New Zealand. Key points. 1. Dietary management is a cornerstone of treatment for patients with type 1 and type 2 diabetes, T1DM, T2DM. Benefits are derived principally from naturally occurring foods rather than supplements or functional foods. 2. In order to achieve compliance with dietary advice, specific goals should be individually negotiated with the patient. Whenever possible, such advice should be given by a counselor specifically trained in nutrition management of diabetes and associated comorbidities. 3. For patients with T1DM who are not overweight, basing dose of rapidly acting insulin on carbohydrate content of meals and snacks, carbohydrate counting, as well as preprandial glucose levels, may be expected to improve overall glycemic control. 4. For those with T2DM who are overweight, controlling energy intake to achieve weight reduction is likely to improve glycemic control to the extent that will obviate or delay the need for oral agents or insulin. If already on drug therapy, intensified dietary treatment may be expected to produce further improvement in glycemic control and often dose reduction. Cardiovascular risk factors also improve. 5. All people with diabetes should aim to achieve intakes of saturated and trans-unsaturated fatty acids which are well below 10% total energy and dietary salt to below 6 grams DA'1 to reduce cardiovascular risk. 6. A wide range of intakes of carbohydrate, 45–60% total energy, mono-unsaturated fatty acids, 10–20% T, and protein, 10–20% T, are acceptable and will depend upon personal preference, extent and nature of metabolic derangement and degree of adiposity. However, carbohydrates should be derived principally from a range of vegetables, fruits, legumes, and whole grains which are rich in dietary fiber and have a low glycemic index. 7. Polyunsaturated fatty acids may be increased from current low levels to a maximum of 10% T and should be derived from sources of both N3 and N6 fatty acids. 8. The wide range of acceptable intakes enables compatibility with the many different dietary patterns of Europe and North America. 40.1 Introduction and Total Energy Intake. Dietary modification is the mainstay of treatment for type 2 diabetes, T2DM. Despite the usually progressive nature of the disease, many newly diagnosed patients with T2DM who comply with dietary advice will show improvement in glycemic control to an extent that will obviate or delay the need for oral agents and insulin. For those who require drug therapy, attention to dietary advice can be expected to further improve glycemic control. 1. In type 1 diabetes, T1DM, dietary advice aims to minimize excessive postprandial glycemia and fluctuations in blood glucose levels. Avoidance of hypoglycemia is a particularly important aim. In all people with diabetes, nutrition therapy is also designed to reduce the risk of long-term complications both by improving glycemic control and by reducing other risk factors, notably dyslipidemia and raised blood pressure levels, for vascular disease. Dietary advice in relation to choices about types of foods for those with T2DM and T1DM is similar, and the major principles resemble those for entire populations at high risk of CHD, coronary heart disease. There is therefore no need for diabetic patients to be given meals that differ from those eaten by the rest of the family. Dietary recommendations for people with diabetes have been made in many countries. It is reassuring that those of the Diabetes and Nutrition Study Group of the European Association for the Study of Diabetes, DNSG, representing the majority of European countries, 2, and the American Diabetes Association, ADA, 3, are generally consistent. These two organizations were amongst the first to issue evidence-based guidelines for the nutritional management of people with diabetes. Any points of difference between the two sets of recommendations are indicated in the text below. Table 40.1 summarizes the basic principles of diabetic dietary recommendations. Total energy intake. The majority of people with T2DM are overweight and usually have other features of the metabolic syndrome: raised levels of insulin, raised triglyceride and low high-density lipoprotein, HDL, levels, hypertension, high levels of uric acid, and elevated levels of plasminogen activator inhibitor 1 in addition to hyperglycemia. Even modest weight reduction is associated with a reduction in insulin resistance, and hepatic glucose production, and perhaps an improvement in islet I circumflex squared cell function. A reduction in blood glucose may be seen with reduced energy intake even before weight loss occurs. In addition to the resultant improvement in overall glycemic control, as measured by A1C, many of the other abnormalities associated with the metabolic syndrome, notably dyslipidemia and raised blood pressure, also improve with weight loss. The improvement in metabolic parameters associated with weight loss is seen not only in the early stages of the disease but has also been demonstrated in patients in whom glycemic control was considered to have been optimized on standard treatment regimens involving insulin and oral hypoglycemic agents. 1. It is generally accepted that total energy, T, should be reduced so that BMI moves toward the desirable range, 28-25 kgma'2. Some Asian populations which are well represented in Europe and North America have a relatively high proportion of visceral fat and central adiposity and an even higher risk of cardiovascular disease than European populations with diabetes. For them a slightly lower BMI is generally regarded as optimal. However, despite advice and support, many people with T2DM are unable to achieve this target. It is important therefore to set realistic goals for weight reduction and to provide intermediate as well as long-term targets. A sustained weight loss of 1–2 kg per month with the aim of achieving a long-term weight loss of 5–7% of starting weight is a reasonable goal for most patients. This can usually be achieved by a reduction of about 500 kilocalories below that required for weight maintenance. Weight loss may lead to greater improvements in cardiac risk factors in individuals with a high waist circumference, but all patients with excessive adiposity, regardless of distribution, should be advised to lose weight. Regular physical activity is generally considered to enhance weight loss and to be particularly important in weight maintenance when targets have been achieved. Behavior modification techniques are an important component of weight loss programs. A wide range of diets of varying macronutrient composition, for example low carbohydrate, high protein, high carbohydrate, high fiber, high fat, and dietary patterns, for example Mediterranean, have been promoted as being the most appropriate options for achieving weight loss in people with diabetes. Appropriate distribution of macronutrients is considered in the sections which follow. However, it should be noted that there is no clinical trial evidence that in the medium to long term, any one dietary approach has advantages over the others with regard to either weight loss or clinical outcomes. 4,5. It is particularly noteworthy that diets very low in carbohydrate may be associated with increases in LDL cholesterol and generally involve the elimination of foods that are important sources of fiber and essential micronutrients. 5. Carbohydrate intakes below about 130 GDA'1 are not advised. The most appropriate approach to achieving weight reduction depends upon the requirements of individual patients. For some it may be sufficient to advise the restriction of energy-dense foods and provide advice with regard to appropriate food types, as well as to provide some general guidance concerning increased physical activity. For those unable to lose weight, a more prescriptive approach based on calorie counting as well as an exercise prescription may be helpful, especially when this approach is used in conjunction with behavioral modification techniques. The role of liquid or solid packaged meal replacements intended to be used instead of 1 or 2 regular meals per day can facilitate substantial energy reduction. However, their place, as well as the role of very low-calorie diets, VLCDs, which provide 800 or fewer calories daily in the management of obesity and diabetes, remains to be established. There is no doubt that they can be associated with rapid and substantial weight loss with impressive improvement in glycemic control. The long-term benefits are less clear since weight regain frequently occurs when normal meals are reintroduced. There is some evidence that despite greater initial weight loss, when VLCDs are used for induction of weight loss, a conventional program is associated with greater sustained reduction in weight and improvement in several clinical and metabolic measures. When VLCDs are used, such as in the management of severe obesity, this should be under the supervision of experienced physicians and dietitians or nutritionists since major alterations in hypoglycemic therapy may be needed and care taken to ensure an adequate intake of essential nutrients. Long-term dietary support, including behavioral modification techniques, are essential. 6. Use of existing weight loss drugs has little or no place in the management of overweight and obesity and diabetes. Appropriately selected patients typically have impressive reductions in body weight and dramatic improvements in glycemic control and some cardiovascular risk factors following bariatric surgery. For those with T2DM who are not overweight, and for the majority of those with T1DM, self-selected energy intakes are appropriate. It is important to ensure that energy intake is sufficient to achieve growth and development in childhood and adolescence. The prescription of insulin in excessive requirements may lead to weight gain. Overweight patients with T1DM can often appreciably improve glycemic control and at the same time reduce insulin requirements if they are able to lose weight. With increasing rates of obesity in North America and most European countries, it is hardly surprising that an increasing number of people with T1DM are also presenting with overweight and obesity and associated insulin resistance. It is important that this situation be recognized and managed with advice to lose weight. Page 579.